Hello, everyone. Good afternoon. I am Teresa Rojas. I'm a pediatric oncologist, and I work as a scientific coordinator for Accelerate. And I'm really pleased to introduce you to the first webinar of this webinar series organized between ERNN PETCAN and Young IOP. We will be introducing different cases through the year, monthly, with the aim of presenting the most challenging cases that we can encounter in pediatric oncology. And today, the first case is called Synchronous Tumours, the chemotherapy challenge for the modern oncologist. It's a fascinating case, as you will see. And we have two excellent presenters. So we have the Young IOP member that proposed the case, Dr. Emma Seaford. She's a training pediatric oncologist based at the Bristol Royal Hospital for Children in the UK. And she's a very engaged, active member of Young IOP. She's currently undertaking a clinical trials fellowship at the Pediatric Clinical Trials Unit in Birmingham. So yeah, I'm really pleased to welcome her to this case. And then, as invited expert, we have Professor Meriel Jenney. She has been a consultant in pediatric oncology at the Children's Hospital for Wales for a long time now, and she's also assistant medical director for cancer services at Cardiff and Vale University Health Board in the UK as well. So about the structure of the webinar, it's really very straightforward. On the first half, Emma will be presenting the most important data about the case, and we will have some polls in between to make it interactive so that you can participate. In the meantime, feel free as well to write questions in the chat. And on the second half of the webinar, we will have time for discussion with Professor Jenney. We will also have time to discuss all your questions and the most hot aspects of the clinical case. And now to the case.
Thank you, Teresa, and thank you so much for the invitation to present this case. So on the next slide, I am going to present the case of a little 5-month-old girl who first presented to us in April 2012 with a 3-week history of what was initially thought to be a squint and then worsening right eye proptosis. She was otherwise well, had an unremarkable antenatal and postnatal history and normal growth and development. On examination, she had a marked right-sided proptosis, but no lymphadenopathy, and the rest of her systemic examination was unremarkable. Bloods showed a mild anemia, but an otherwise normal count. She had normal renal and liver function, and her AFP and HCG were within normal limits for her age. So on the next slide, please, we went on to do imaging of her head, and this confirmed the presence of a retroorbital lesion around 2 centimeters in all dimensions, which was avid with contrast enhancement, although darker centrally with a cystic or perhaps necrotic region and a normal optic nerve. So I'm going to pause at this point and pull up the first poll and just say, with the information that you have so far, what would you say would be your top 3 differential diagnoses for this little girl? So grab your mouse and click on the options on screen. I'm looking for your top 3 differential diagnoses from leukemia, Langerhans cell histiocytosis, retinoblastoma, rhabdomyosarcoma, or neuroblastoma. I'll give you about 10 seconds or more to have a think about that and pop your responses on the screen, and then we'll have a look to see what the answers are. Quite even split. So the majority of you voting for rhabdomyosarcoma is your most likely diagnosis, followed by neuroblastoma and retinoblastoma, and those are exactly the differentials that we had at the top of our list at that stage. Whilst this would be a quite classic presentation for a Langerhans cell histiocytosis, she's very young to be presenting with that, so that would have dropped down my differential list. And leukemia absolutely would have been there, probably in the 4th slot, thinking particularly of a myeloid leukemia, although slightly less likely than normal count, but absolutely still possible. So if we could go back to the presentation, we were very surprised on her imaging, on the next slide, to find that she also had a second lesion. I don't know if we're able to bring up the picture of the next slide in the presentation. I can't see that at the moment. So we found that she also had a second mass in the occipital horn of her right lateral ventricle, around 1.5 centimetres in diameter, on the next slide, which led us to wondering, what was this second lesion? So was this on the next slide please, a metastasis from the retroorbital lesion, or was this indeed a second primary? Thank you. So the biopsy of her retroorbital lesion had confirmed that there was to be some type of sarcoma, which made us think it was a little bit less likely to be a metastasis, but still possible. But we felt that we needed to be completely confident around the pathology of that second lesion because of the significant implications for planning her treatment. So a decision was made to proceed with a surgical resection of the choroid plexus lesion up front. Next slide, please. And this showed that we did in fact have two distinct entities. So looking down the microscope, we could see from the retroorbital lesion interlacing fascicles of spindle cells with densely eosinophilic cytoplasm, whereas a choroid plexus lesion showed polygonal or round cells predominantly in sheets with a focal papillary pattern. And that distinction was even clearer looking at the immunohistochemistry, with the retroorbital lesion testing positive for the muscle markers desmin, myogenin, and MyoD1, whereas the choroid plexus lesion was negative for those markers, but positive for pancytokeratin and S100. So we reached the conclusion that we had synchronous tumours, firstly a spindle cell variant of a rhabdomyosarcoma, and then also a choroid plexus carcinoma. On the next slide, please. So that led us to wondering why we had synchronous tumours in this young girl. And she presented at a very young age with both of these, and they're both tumour types that are typically associated with predisposition syndromes, especially that choroid plexus carcinoma, which in 40% of cases is seen in the context of an underlying Li-Fraumeni syndrome. So we thought this was almost certainly indicative this young lady had a cancer predisposition syndrome. The only thing going against that was there was no significant family history of cancer, even on careful review, although that obviously did not rule out there being a de novo mutation in our patient. So she had some genetic testing sent, and the family were counselled about the implication of those results, especially with regard to her 18-month-old older brother. Next slide, please. So we then moved on to staging the tumours, and she had a bone scan, bone marrow sampling, an MRI of her spine, and CSF sampling, all of which revealed no metastatic disease. So on the next slide, please. And with regards to her rhabdomyosarcoma, she falls into a standard risk group, subgroup C, on the basis of favourable pathology, favourable site, and no nodal disease. Next slide, please. With regard to the choroid plexus carcinoma, in addition to it being localised, she'd had a gross total resection and there was no residual disease. So overall, we spoke to the parents about the complications of this situation and the difficulty in giving a prognosis, that we thought the poorer prognosis probably came from that choroid plexus carcinoma with an anticipated cure rate of around 50%. Next slide, please. We then moved on to thinking about her treatment. And we knew that we needed to get good local and systemic therapy for both of these tumours. She'd already had a total resection of her choroid plexus carcinoma, and we knew there was no residual disease. So in the context of her age and that lack of residuum, we knew that radiotherapy was not indicated from the point of view of her choroid plexus carcinoma. With regard to the rhabdomyosarcoma, there was generally no role for surgery upfront in retroorbital rhabdomyosarcoma, and we left the decision around radiotherapy until we had seen her response to chemotherapy. Because whilst we were keen to avoid radiotherapy on the basis of her age and possible underlying genetic condition, we were aware that the majority of children in this situation did require radiotherapy for local treatment. Next slide, please. That then led us to the very difficult question of what to do with her chemotherapy. We wanted to treat both tumour types with optimum chemotherapy, acknowledging the poorer prognosis of the choroid plexus carcinoma, but not really wanting to compromise the chance of cure from her rhabdomyosarcoma. Typically, we would have treated her rhabdomyosarcoma with 9 cycles of IVA, given every 21 days. And the choroid plexus carcinoma, we would have treated with etoposide, vincristine, and either carboplatin or cyclophosphamide, given every 28 days for 6 cycles. So again, I'm going to pass this question over to you. So if you could bring up the next poll, please, that'd be brilliant. And I'm going to ask you on this one, what chemotherapy in this particular situation would you have given? Would you have followed the rhabdomyosarcoma guidelines? Would you follow the choroplexus carcinoma guidelines? Or would you have given some combination of chemotherapy agents in an individualized protocol? Again, about 10 more seconds to grab your mouse and click on the screen, and we'll get that feedback up on the screen once the poll has closed. Fantastic. So the majority of you aiming for some sort of individualized protocol, beyond that slight preference for rhabdo over a choroplexus protocol. Brilliant. If we could come back to the presentation, please. Thank you. So that's exactly what we decided to do. We decided, onto the next slide, to give a bespoke individualized chemotherapy regime. And our intent was to incorporate 9 cycles of either ifosfamide or cyclophosphamide as the backbone of her rhabdo treatment. We incorporated vincristine because that was a chemotherapy drug that was relevant to both schedules and obviously not so myelosuppressive. And we gave that according to the rhabdo schedule, so weekly for the first 7 weeks and then every cycle. We also wanted to include actinomycin D to complete some rhabdo treatment, but plan to alternate that with cycles containing etoposide and carboplatin to maximize her therapy for the choroid plexus carcinoma. So the sum total of that was that we came to alternating cycles of 3 different combinations: traditional IVA, VCICE, which is vincristine, cyclophosphamide, carboplatin, and etoposide, and IVE, so ifos, vinc, and etoposide. Next slide, please. And we chose those cycles because they were ones that were used in other protocols, so we knew that they were tolerable and we knew what the myelosuppressive effects were, so we knew we'd be able to keep the chemo intensity. And we also had an eye to the total cumulative doses of each of the agents. So we were trying to target a total cumulative dose of each of the drugs that was equivalent to that she would have had on both the rhabdo and the choroplexus schedule. So for example, the etoposide, we only gave in every 2 out of 3 cycles, but over the course of her 9 cycles, she's had the same cumulative dose of etoposide as she would have received on the choroplexus carcinoma schedule. On to the next slide, please. So she tolerated this chemotherapy well. She had a single episode of sepsis that required a central line change, but overall no significant delays in receiving her chemotherapy. On reassessment, we could see that she had a good partial response with just over 50% reduction in the size of that mass, but that still left a significant residual. We also, while she was having her chemotherapy, received the results of her genetics testing, which confirmed that she did indeed have a pathogenic P53 mutation, confirming an underlying diagnosis of Li-Fraumeni syndrome, which, as most of you will know, is a rare autosomal dominant inherited condition with a significantly increased lifetime risk of cancer. So the figures that are out there is that by the age of 5, approximately 20% of these children will have experienced cancer. That rises to 40% by the age of 18 years and is nearly 100% by the age of 70 years. So that left us with the very difficult question of what to do with the radiotherapy. We know that local therapy is key in rhabdomyosarcoma, and I've already mentioned that we tend not to use surgery up front for an orbital rhabdo, which would leave radiotherapy as the modality of choice. But we had some concerns around that based on her very young age and the evidence of increased risk of radiation-induced cancer and Li-Fraumeni syndrome. And generally, you're advised to consider alternative therapies to either minimise or avoid radiotherapy use where possible. So for your final, really straightforward question, I would like to open up the last poll, which is, in this situation, what would you have chosen to do with that radiotherapy? Would you go ahead and give it? And if so, would you ideally prefer external beam or proton beam, or would you have avoided it in this situation? I'm afraid you still only get 10 seconds to think about this question and pop your answer up on the screen. I'm very intrigued to see what we get back on this question. So the majority of people going for radiotherapy, absolutely nobody wishes to do that via external beam, which makes sense. Everyone preferring to do that by a proton beam, and a third of people opting to avoid radiotherapy in the situation. If we could come back to the presentation, please. So we decided to proceed with radiotherapy. On the next slide, please. Thank you. And we were unable to access proton beam therapy for this patient, so we delivered external beam radiotherapy. And the reason we decided to proceed with radiotherapy was that a multidisciplinary team felt uncomfortable with the size of that residual mass and felt that the balance of benefit to risk in this situation was to treat what was there in front of us. So having counselled the parents about the risks associated with radiotherapy, we delivered 36 Gray to the whole orbit and boosted the original tumour volume to a total of 50 Gray, which she tolerated well. Next slide, please. Having completed her treatment, we then moved to worrying about the long-term toxicities, because we were very conscious that we'd given a very young child both intense chemotherapy and radiotherapy. And she was lucky enough not to see any significant toxicities in those early years. She was well, she had normal organ function, and she attended mainstream school with no evidence of any cognitive or learning difficulties. She did have some mild facial asymmetry and reduced vision in her right eye. And on endocrine follow-up, we could see that she had a borderline cortisol level and suboptimal growth hormone, although she was growing well along the 25th centile and did not need any replacement hormones. Regular MRI scans showed no evidence of recurrence. Next slide, please. Unfortunately, following her treatment, her family still had a very difficult couple of years because her older brother, who was 18 months her diagnosis and coming up to 3 at the time of his diagnosis, was diagnosed with a grade 3 anaplastic ganglioglioma. Rapid genetic testing confirmed he had the same mutation, P53 mutation, as his sister, and despite treatment with radiotherapy and temozolomide, he relapsed very quickly and unfortunately died. It was clear to us at this point that this was in fact not a de novo mutation in our little girl, and the parents were both offered genetic testing. Mum went ahead and was found to not have the same mutation as the children, and after that point Dad declined to come in for testing himself. So we're not clear at this stage whether Dad has the mutation or perhaps one of the parents is a gonadal mosaic. Next slide, please. And so just to bring you up to date with where we are with this girl at the moment, she represented to us at 9 years of age, 8 years after finishing her previous treatment, with a rapidly growing mass arising from the right side of her palate. She underwent biopsy and staging and was diagnosed with a localized sarcoma with malignant osteogenic differentiation of her right maxilla. Unfortunately, that did fall within the margins of her previous radiotherapy field, so is most likely a radiation-induced second malignancy, or third malignancy in her case. She has had radical surgery, she's had orbital exenteration and a maxillectomy, and is continuing her treatment with us currently with chemotherapy. The next slide, please. Thank you very much for your attention. I'm very happy to take any questions about this case, and I'm going to pass back to my colleagues to lead some discussion around the chemotherapy regime, the use of the radiotherapy, the long-term implications for this little lady, and whether a regular screening for malignancies and context of Li-Fraumeni syndrome would perhaps have been something we would have done in this case at a different time point. Thank you.
Thank you, Emma. That was brilliant. I think this case raises a number of very interesting issues, as you mentioned, some of them. I don't know which one Professor Jenney would like to start commenting on. Please go ahead.
Thank you very much, and thank you, Emma. That was very clear and clearly a complicated patient. I'm not sure that there are questions coming in yet that I can see, so I'm happy to comment and perhaps discuss with you in the first instance, Emma, about the rationale. So the challenges really of chemotherapy in this situation where you have more than one tumour, or where you have a tumour. The other situation this arises is where there's a tumour which is not clear cut, where there's elements of maybe an intracranial tumour and some other sarcomatous tumour. That's certainly something we've seen. And it's that balance, isn't it? Not just about the regime, but the challenges here are CNS penetration, so reflecting on which drugs are going to get into the CNS best out of the ones you choose. And the other thing I think it's worth reflecting on is the age of the child. You commented that she tolerated it well and had only one episode of sepsis. So the obvious question is, did she have enough chemotherapy? And I think one of the issues we see, particularly in rhabdomyosarcoma in the younger patients, and They probably do more poorly because of the biology of their disease, but it could be that we undertreat them, either by chemotherapy, because we have to be careful, because we have to dose based on weight and size. But I think there's more we could be learning about the pharmacokinetics of the drugs we're using in infancy, and I think that's an area that we could optimize in terms of treating patients. So that's my first reflection. The other is, as you know, should you have given radiotherapy in this situation? And my reflection on that is that there's no absolute right or wrong here, particularly in the context of Li-Fraumeni. So it would be fair to say you'd be entirely within your rights to not have given radiotherapy to a child under the age of 1 or just over the age of 1. But it was clearly the right decision, at least for the first 9 years of this child's life, to have given radiotherapy because of that residual tumour. I think you were right to be concerned about the size of the residual tumour, and based on what I've just reflected on, there may have been an element of a lower dose of chemotherapy delivered than might have been optimal, particularly from the point of view of rhabdomyosarcoma. So whilst embracing both tumours, the chemotherapy for rhabdomyosarcoma was compromised, and therefore it was, I think, entirely reasonable to give radiotherapy. I'm not sure you mentioned that the reason you couldn't do proton was because of the second cancer. At that time, the indications were far more stringent, and I think we would probably be arguing more strongly now for its use. But this is a big dilemma and a recurring one in infants, hence my comment about optimizing chemotherapy as much as we can.
Professor Jenney, we have actually, in line with what you were commenting, 2 questions about the local control.
Yep.
One by Kok Hoi Te. He suggests that perhaps excision of the eye would have been a better local control strategy instead of the radiotherapy, precisely because of all what you just mentioned. And also Reineke Skut asks whether surgery with brachytherapy would have been also a possibility for local treatment in this case.
So both are possibilities. Although brachytherapy up front is rarely used. We had a pre-discussion about this, and at this site, the commonest site it would be used really is in bladder prostate rhabdomyosarcoma and sometimes perineal rhabdomyosarcoma. I think the comment about exenteration is interesting, and now I think would I be right, Emma, that she's gone on to have an exenteration for the second cancer?
Correct. Yep.
I have a strong view, perhaps not so much in the orbit, that surgery has a lot, has a great role to play, and we shouldn't be frightened of it in sarcomas in very young children, particularly in limb sarcomas, when the impact of radiotherapy is so profound, particularly on the lower limbs, whereas actually functional outcomes with amputation can be extremely good, particularly if done at a very young age. So that balance is always impossible, because you're not going to ever understand how the child's going to adapt psychologically to what you do, and cure is the most important thing. So I think that's a very good question. I think the balance between exenteration and radiotherapy is a difficult one. There is no right and wrong in this situation. There can be, I have to say, sometimes there can be a right or wrong, but I think here an informed discussion with the family about balancing all these risks and benefits is all you can do. And of course, retrospect 9 years later is a very different world to where you are at the time. Are there more questions, or shall I?
Yes, we have another comment, more than a question, it's a comment by Karel Svoiger, saying that radiotherapy, not only because it's a small baby, but because it's a small baby with Li-Fraumeni syndrome, is highly controversial. Yeah. We've also covered this a bit, but perhaps you want to comment on this combination of both factors.
So Emma knows what I think. I agree. I think it's highly controversial, particularly with the Li-Fraumeni. But I think the outcome for this child has been really quite good for the length of time in this situation. Unusually, I'm not sure I would have given radiotherapy, but that's not meaning that this is right or wrong. I think what we want to describe here is the true sort of equipoise or unknown that we so often see in paediatric oncology, and our responsibility is then to be sharing that with the patients, and so they understand and are with us as we're honest about that lack of clarity. There's no randomized trial, but I would agree that in the context of this age and with Leaf-Ramini, it is difficult, and in retrospect you might have done something different, Emma, I don't know, but I wouldn't criticize. It's very important as a community to be careful how we criticize others' decisions in the round. Were there any discussions you had with the family that led you one way or the other, Emma, or it was you know, I would just comment, the trouble with exenteration is getting clearance, and we really don't ever use surgery at this site under normal. That would have been an exception because of the Leaf-Ramini. Go on, Emma, sorry.
No, I was only going to say the family were very aware of all of the risks and benefits, and were generally guided by the medical opinion in the situation, and the feeling within our MDT was quite strongly that the radiotherapy was the right thing to do. They just weren't comfortable with leaving that residual disease at that size for this patient.
I'm aware of time. Am I right? So can I just make a couple of comments? One is that in terms of the longer term implications. So Emma described quite, moderate side effects, and this child was, let's ignore the second cancer for a minute, which is obviously the most important thing. Don't forget the child will go through puberty, and the difference through puberty that will become manifest can be quite profound, particularly in terms of facial deformity and asymmetry. So I think it's early days, and this is again one of the challenges in rhabdomyosarcoma, that so many are treated so young, and we really do have to follow them up to understand their longer term effects. And I didn't want to pass without, do you have a slide on the screening schedules? Because I think it's good to share those, because that's another controversial, well, less and less controversial area where it would be important people were aware of the current recommendations about screening.
Yeah, there's a slide right at the end, Martin, if you could flick to. And at the time that our patient was in her follow-up, the screening was not, oh, sorry, that will be fine, lovely. Screening was something that we didn't routinely do in the UK, but certainly at this stage, we now have agreed UK guidance, and I know there's generally international guidance out there around screening, and we certainly, for any new patients at this stage, would enrol them in a screening program that involves roughly abdominal ultrasounds every 3 to 4 months in childhood, an annual whole body MRI and a brain MRI annually, and then as they become older, we would introduce breast screening with MRIs and possibly colonoscopies also, as well as regular physical exams, including examination of the skin.
Thank you.
We're coming close to the end. I think Emma wanted to highlight some take-home messages, and then we can wrap it up if Professor Jenney agrees as well.
No, very happy with that. Thank you.
Thank you. So when I was thinking about this case, I thought one thing that stood out to me is that we're very familiar with treating children according to our protocols now, but actually retaining a really good understanding ourselves of the contribution of each drug to that protocol, what that brings, what its effects are, is very important when we come to these more complex decision makings where they don't fit within a protocol. I also thought we'd need to keep a very low threshold for undertaking genetic testing for those tumours presenting either at a young age or simultaneously, because it can have a really significant impact on our treatment decisions. And also, just to reflect what Dr. Jenney has already acknowledged, is that these treatment decisions are very complex, and often there isn't necessarily a right or wrong, and we just have to try and balance the benefits and the risks with support from our colleagues and the experts around for each of the relevant conditions, as well as really open and honest conversations with the families to see what their preferences would be. Dr. Jenney, I don't know if you've had anything you would like to add as a take-home message for the audience.
No, I think that's great, and I think the questions were helpful, and I'd like to thank you for your really clear presentation and summary. So we'll be very keen to get feedback on how this. I'm sure Teresa's about to say that, but thank you very much indeed, and thanks to all of you who've joined. It's been a great attendance. Back to you, Teresa.
Thank you all. Thank you both for this excellent case and for the discussion. And we will see you all again in a month. Thank you.
Thank you very much. Goodbye.
Goodbye.